Okay, so this is a lecture on cervical part of the sympathetic trunk, where I'm taking reference from this book, that is P.T. Chaurasia, and it is of 9th edition. So why we need to study this topic? So firstly, why is there no sympathetic supply from cranial nerve? You might ask. Well, the sympathetic fibers from hypothalamus, they run in the spinal cord, okay, literally, and then they come out from the cranial nerves. Oh, sorry, from the spinal nerves, not from the cranial nerves. Okay, that's why we study the spinal nerves in this one. So we have two trunks, the right and the left, one on each side, okay, and they are situated on the cervical part of the vertebral column behind the carotid sheath and its content also, and it's in front of the prevertebral fascia. Let me draw it for you. So presume this is the prevertebral fascia, and then this is the carotid sheath. So here lies the sympathetic trunk, okay. That's how you imagine it. And then how is it formed? It is from the it is not from the white rami communicants, it is from the gray ones, okay. And it is from the T1 and T4 segment. You might ask, what are white and gray rami communicants? They are nerve branches that connect the spinal nerves to the sympathetic trunk, and they transmit the autonomic signals. White ones are myelinated preganglionic fibers, while the gray ones are unmyelinated postganglionic fibers to target organs. Okay, you can see here this one, right? So this is a schematic diagram of the cervical sympathetic trunk and its branches. But we will study it later. Firstly, we will study the overall relations. As I said that it is behind the carotid sheath. So what will be its anterior relations? We see that it's anterior to this is the sympathetic trunk, right? What is anterior to it? It's the carotid sheath. This is the carotid sheath. And here we have the internal carotid artery and common carotid artery, because the external is outside the carotid sheath, right? And here we have the vagus nerve also, and we have the internal jugular vein also. And also there is one more, that is the inferior thyroid artery, which lies anterior to it. And posteriorly we have the prevertebral fascia. There will be two muscles behind it, longus capitis and cervicis muscle, okay. And also, as I told you before, the transverse processes of the cervical vertebra. And now you might ask, what is a ganglion? There might be a question in your mind. So there are structures in peripheral nervous system that consist of clustered nerve cell bodies that act as relay stations for nerve impulses outside the brain and spinal cord. Okay, so main thing you need to remember is they're outside the brain and spinal cord. Of course, that means they are in peripheral nervous system, and they're nerve cell bodies. Okay, they act as relay stations. So there should be 8, right? 8, one for each cervical nerve, but there are only 3. Why? Due to the fusion. So superior, middle, and inferior. Upper 4 ganglions fuse to form the superior cervical ganglion, then the next 2, and then next 2. So firstly we will see the superior cervical ganglion, which is the largest of the 3. It is spindle shape and 2.5 cm long. It is situated just below the skull and opposite the second and third cervical vertebra, behind carotid sheath and in front of prevertebral fascia. Formation is by upper 4 cervical ganglion. What are its communications with the cranial nerve 9, 10 and 12? There might be a question in your mind, why not the 11th, the spinal accessory nerve? Why not a connection with that? because that nerve doesn't carry any sympathetic uh, fibers. It is purely motor, and there are its communication with internal and recurrent laryngeal nerves, which are of the vagus only. Okay, and we will see the branches. There are 5 branches. We will see it here. So firstly, we have these gray rami communicants to cervical ventral rami. That is 1, 2, and 3, 4. So first, 4 cranial nerves have communications from this one. Okay, as I told you that it is due to the fusion of upper 4 ganglions. Then we have a branch going to the external carotid artery, that is the external carotid branch. Then a branch going to the internal carotid, that is the internal carotid nerve. Then we have a branch going to the pharynx, that's the pharyngeal branches. Then another branch which is going to the cardiac plexus. One is superficial plexus, one is deep. So the left one, you need to remember this, the only branch from these ganglions that supply the superficial cardiac plexus is the left superior cardiac branch. Okay, the left superior cardiac branch supplies the superficial cardiac plexus. Okay, the other one goes to the deep. And also from the middle and the inferior cervical ganglion, the branches go to the deep cardiac plexus only. Okay, so we did this. And so what do these plexuses supply? So this one will go to the dilator pupillae. We will see it in the ciliary ganglion. Like the sympathetic fibers come from the internal carotid plexus and they go as the deep petrosal nerve to dilator pupillae. I'm sorry, there is a direct branch from dilator pupillae, and the other is the deep petrosal nerve which go to the pterygopalatine ganglion. This one goes to the ciliary and this one goes to the pterygopalatine. And also there are long ciliary nerves for the ciliary ganglion. And what the plexus around the external carotid does, there are some fibers going to the aortic and some fibers going to the submandibular ganglion. Pharyngeal branches we have done, and this also we have done. Then we move on to the middle cervical ganglion. It is very small. It may be divided into 2-3 parts or may be absent. Its situation is in the lower part of the neck, in front of C6 vertebra, just above the inferior thyroid artery and behind the carotid sheath. This one was in just below the skull and opposite second, third cervical vertebra. Okay. It is formed by fusion of 5th and 6th cervical ganglia, and it has connection. Its connection with the inferior cervical ganglion is direct and also indirect. Let's see here in the diagram. So this is a direct connection of the middle with the inferior cervical ganglion, and this is the indirect one. See, it is known as ansa subclavia, which loops around the subclavian artery. Okay. Ansa means loop. We know that there is ansa cervicalis also, or ansa hypoglossi. So this is ansa subclavia. Its branches we have 4. Let's see in the diagram. So we see 2 are the gray rami communicants with cranial nerve 5 and cranial nerve 6. One is going to the thyroid gland, and some are going to the trachea and esophagus, and also we have the cardiac branch, middle cardiac branch. They were superior cardiac branch, here we have middle cardiac branch. As I told you that only the left superior cardiac branch goes to the superficial cardiac plexus, every other branch go to the deep cardiac plexus. And so the thyroid branches go by accompanying the inferior thyroid artery to supply the, and also they supply the parathyroid gland. And one thing you need to remember is that the sympathetic fibers or supply is always from, it always winds around some arteries. The main arteries, okay, they wind around the main arteries and they follow these arteries and then supply the specific target. Okay, then we move on to the inferior cervical ganglion. It is by the fusion of 7th and 8th cervical ganglia, and it is often fused with the first thoracic ganglia also. And when this is fused with this first thoracic ganglion, we call it as stellate ganglion or cervicothoracic ganglion. Why do we call it as stellate ganglion? Because it is face shaped? No, it is star shaped. Where it is situated? It is between the transverse process of 7th vertebra and the neck of the first rib, and behind the vertebral artery. We know that vertebral artery. So it is behind the vertebral artery and in front of the ramus of spinal nerve 8. Okay, and if it is the cervicothoracic ganglion, it will extend in front of the neck of the first rib, while when it was inferior cervical ganglion, when it was the inferior cervical ganglion, it was only in between these two structures, right? When it is cervicothoracic ganglion, it extends in front of the neck of the first rib. So what are the branches? Again, we have 4 branches. We will see in the diagram only. So we have the inferior cervical ganglion here, and again we have the great rami communicants, the 7 and 8, okay, and one branch is going to the vertebral artery. It will form a plexus again, and then we have the inferior cardiac branch, and one branch is also going to the subclavian artery. Let's see. This is done. Then we have vertebral branches that forms the plexus around the vertebral artery. We have the subclavian branches which forms the plexus around the subclavian artery, and it is joined by the branch from the ansa subclavia. And we have again this one, inferior cervical, it is cardiac. Inferior cardiac branch which goes to the deep cardiac plexus. Then we have the clinical aspect. Okay, so as I told you before that the sympathetic supply of the head and neck, it arises from the upper 4 thoracic segments of the spinal cord. Upper 4 thoracic segments of spinal cord, that is T1 to T4. Then most of these preganglionic fibers, they pass through the inferior cervical ganglion and do not relay there, okay? They do not relay there, and they go up to the superior cervical ganglion and relay in that. And there are postganglionic fibers that go and supply the head and neck. So then we have the Horner's syndrome. It is due to the injury to cervical sympathetic trunk, and it all can also be caused by lesion within the CNS or anywhere at or above the T1 segment, as all of them were arising from the T1 segment of the spinal cord. That involves the sympathetic fibers in the lateral, the sympathetic fibers, they lie in the lateral region of the spinal cord. So any lesion here will affect it and will cause the Horner's syndrome. So what are the characteristics of this syndrome? I drew this as much as you can to help you remember this. Okay, and this is the normal side, this is the affected side. So first of all, what we see here we see that the eyelid is drooping, that is ptosis, then drooping of the upper eyelid. Then we see that the pupil is constricted, that is meiosis. Then we see that there is no sweating, but here we have the sweating, that is anhidrosis. Then we see that the eyeball is smaller, that is retraction of eyeball, that is called the anophthalmos. Then we have the loss of the ciliospinal reflex, which is when we pinch the skin on the nape of the neck, there is dilation of the pupil. But due to Horner's syndrome, there is loss of this reflex and that do not produce any dilation of the pupil. Okay, so this was it. Hope you find it helpful. And thank you very much. Hope you will subscribe and like and comment on what topic you need the new video. and any improvements you want, please tell me in the comments. Thank you again.